Yeah, hi, my name is Bruce Crispin, and I'm a board certified fixed prosthodontist, an accredited member of the American Academy of Cosmetic Dentistry, and the owner and CEO of Aesthetic Professionals Dental Education Center in Tarzana, California. What I'd like to do in this short webinar today is just give you kind of a preview of what we teach in our course that's coming up on September 22 and 23 of this year. And it's really Introduction to Complex Fixed Prosthodontics. I think a lot of people are just overwhelmed by complex cases, so they don't do them. Or they don't know how to segment them so patients can afford them. And the whole program is really to teach you how to handle patients, how to organize patients, how to break treatment down into simple steps so they're not so complicated, and also break it down for the purposes of maybe spreading out the costs. And so what I'm going to do in this short webinar is just give you a couple of quick cases, just kind of an overview, kind of an introduction to what we teach in detail in these first couple of days. And if you're interested in mentorship, we can spend several days going through a lot of cases. But anyway, let's talk about a couple of cases just to give you an idea of, and a preview of what the program is all about. Okay, I have a classification for my different cases. This happens to be a Class 2 case, which means some of the restorations are bonded, some of them are cemented. And so I think that'll become clear as we go through this. But it also is a vertical dimension case, and I think a lot of dentists are really intimidated by changing vertical dimension. And it's really not that complicated. I can show you how to handle this where anybody can master it. And again, it's not that difficult. It's just really all a matter of learning how to do the simple steps. Okay, and so really this first step is a male, and we're going to break his treatment down into phases. So we're going to start and stop, start and deliver different phases, which would be similar to a case where you're going to spread out the cost maybe for insurance, or spread out the cost for the patient's ability to pay. And the reality is, if patients can afford 6 or maybe 8 teeth at a time, you can do full mouth reconstructions. Obviously, if you're doing one at a time, they're probably not going to get a full mouth reconstruction. But if they can do 6 teeth at a time, you can do full mouth reconstructions. Okay, so let's start walking through the process. And that's really just what I'm going to show now is just an overview of the process. Clearly, you have to identify the problems, and when restoring an entire mouth and changing vertical dimension is difficult, and especially if you're breaking into phases. And I think herein lies one of the reasons that a lot of doctors don't like to treat cases. And so how do you get from before and after and break it into phases and end up with a case that works and functions and feels good and looks good? Okay, well, the process is basically the same, and what we really focus on in the course is not only how to break things up into workable parts, but how to organize them. And really it all boils down to these simple steps, and I call it the plan of treatment. So initial patient phase, diagnosis, emergency treatment plan, which is really the first phases. And so this is what I call our diagnostic phase, and every phase we like to take lots of photographs. And we use those photographs to show the patient, but we also use them to do our diagnosis. And so when I'm doing my diagnosis, I'm doing it in front of my patient, so I'm doing everything simultaneously. So we're learning together and talking about things. And you can see over here on the left, this patient really, and on the right too, I'm sorry, the patient's right and the patient's left, you can see that we've really got a loss of vertical dimension, a lot of wear, and there really is very little room for crowns. And so, and you also see in the anterior a lot of wear, and so clearly in this particular case, we're going to do some vertical dimension increase. Now you could do crown elongation, I guess, but I think it's a whole lot easier to do vertical dimension increase, especially when they lost vertical. And so this case, I think clearly has made it a whole lot easier just by opening the vertical, giving yourself enough room to restore the restorations. You can see dentists have gone in and tried to do a crown here and a crown there, but they end up with little short, stubby crowns. They totally ignore the anterior wear, which is significant, and a significant part of why they have the posterior wear. So we mount our models, we mount them at an open vertical, and we try to guesstimate where that vertical is by making an anterior stop. This is somewhat of a guess in the beginning, and throughout the course of treatment, we finalize our vertical dimension, do our full mouth x-rays, and then we can get the patient back and we do a comprehensive exam. We show them the pictures, we do a consultation, we go through all of this. So by the time we're done with our consultation, we've come up with a treatment plan, which is pretty accurate, and we can start talking about fees. And if the patient is still on board with the fees, and again, if you can phase it, it makes it easier to get them to become on board. And quite frankly, in this particular case, the patient doesn't have a whole lot of choice. If they want to fix their teeth, I guess the other choice would be to do dentures or all on four or something like that. But with this many teeth that are in reasonable shape, I think that would be kind of a travesty personally, especially if you can make it so they can afford it. And then we come up to the next phase, which really is coming up with our digital prototype. We've toyed around with a bunch of different techniques, and I'll show you a couple in these two cases. These are a little bit too white, I think. We put a little pink on them to make them look nicer. These are digital printed diagnostic workups that we did. These can be mounted or unmounted. It depends on what we want to do. We use these for provisionals. We use them for what we call matrix bonding. I'll show you that in a minute. And then we do our final consultation, and then if we're all on board, and again, at this point, we had a few patient contacts. We've had 2 or 3 appointments. We get to know that patient. We get to know if they're cooperative. We get to know if we really want to treat them, and whether or not we want to raise our fees even more, possibly, if they're going to be someone that's difficult to handle, or maybe if you just don't want to handle it, you're going to refer them, I guess. But by this time you have a pretty good idea if the patient is nice and you've got a compatible relationship. And now we can do our plan of treatment, which we've talked about in part. And so now we're really getting into the restorative phase, which is the main part of the treatment. We actually write down every appointment, what we're going to do, how long we want the appointment to be, what lab procedures we want. This is all part of what we teach in our program. And we do that before we start. Now the first step really is what we call pre-restorative treatment. Okay, and we're going to do some matrix bondings. What is matrix bonding? Well, basically we're going to take a couple of hours and we're going to restore his upper arch by bonding on restorations that pretty much look like the diagnostic wax-up. So it gives the patient right from the very beginning an aesthetic preview, and it makes them look a whole lot better right from the beginning. Nothing like getting your patient happy right at that first 2-hour appointment. We start increasing the vertical dimension. We test our occlusal scheme. If they have symptoms, we can start working on symptoms by modifying their occlusion. If that's going to solve the problem, relax muscles, because we certainly need to have relaxed muscles before we continue on with the process. And so we just marking their stent. And usually we do this in phases. We teach that in the program. That's actually what you'll learn in the first couple of days in this program. And we do our matrix bonding. Now these are a couple months old, so you can see they're getting a little bit discolored. But actually these hold up pretty good. And we've already opened the vertical about half to 2/3. We've given the patient an idea of what their teeth are going to look like as far as their length and form. And so now we're ready to start our sequence. Now if the patient tolerates that fairly well and they don't destroy them, that goes a long ways to determining whether or not we need to have stronger materials or weaker materials. In this particular case, we decided to do Emax veneers, lower first buy to first buy, upper layer of zirconia in the aesthetic zone in the uppers, and then in the molars we're using zirconium, monolithic zirconium. And we're using multi-layer, so they're going to be pretty aesthetic, as you'll see. So the first phase, we're going to do our veneers on the lower. And once we do our lower veneers, now what we've done is we've actually established our vertical dimension. Okay, we put the veneers in. Any adjustments necessary, we adjust on the upper matrix bonding, so we don't have to touch those lower veneers. We make them ideal. And after we're done, now we've got the vertical dimension, and we've also got a posterior open bite. Next phase we're going to do, now those are cemented. The next phase we're going to go ahead and do our upper teeth. So we're going to try to match the lower veneers as much as possible. If we need to make some adjustments, make them brighter, make them darker, depending. This is usually a good way to do the lowers first, because we can finalize our aesthetics when we do the upper anteriors, which are really the most critical when the patient smiles. Okay, so here's our upper. We did 8 teeth, and then we went ahead and delivered those. Conservative margin placement, and if you look at the back, you can see how much we've opened the vertical dimensions. They're pretty significant in this case. What's the significance of that? if it was going to go for years, it might be significant. You might want to make some temporary occlusal stops. In this particular case, we really were just talking about months. And if you get a little hypereruption, quite frankly, it's no big deal. Patients tolerate this quite nicely. And really, when they've only got anterior stops, they can't bite that hard. And these are all some of the things that we teach in this program. And then we went ahead, and now we're going to do our left posteriors. So we did his left posteriors in one phase. And we went ahead and cemented those. And then we went ahead and did his right posteriors. And those are just the solid models, not our die models. And then we went ahead and delivered those. So now you can see we were able to break this into lower anteriors, upper anteriors, right side, left side. So we had 6 different phases. Could you break them up into even more phases? You could. You could break up the upper anteriors, the posteriors, and upper and lower phases. So there's a number of ways, but this would be at least 6 phases. And so you're breaking the cost of a fairly expensive reconstruction into 6 phases. Okay, here you can see the before and afters again. Here's our right side. Here's our left side. Here's our post-op x-rays. And then our post-operative treatment. We make post-operative splints. I call this our insurance plan. We want something to protect your patient's investment, but we're also going to use it to evaluate compliance. Part of the patient compliance is to wear the splint, and if they don't wear the splint, they're not compliant. And if they come back and something happens, they break something, let's say, I always make sure they bring in their splint. And if they come back and their splint obviously hasn't been worn, clearly they're not compliant. And a patient that's not compliant, should we really be responsible for if they break something? If they come back and don't come back for recalls and cleanings, are we responsible for their periodontal disease? Same thing. So patient compliance, and we talked about this, the patient, we emphasize it, we have discussions and consultations, so it's a significant part of the longevity, and they've got a pretty big investment to protect here. So here we can see our post-op, patient happy, paid his bill, and now he's on his way. And he referred his wife in. So the next patient actually is his wife. She also needed a slight vertical dimension increase, but this one we completed all at once. We handled this a little bit differently. Okay, so first, same diagnostic wax up, our workup, our diagnostic phase, take lots of pictures, full face, smiles, right, left laterals. So the patient, when we go through this with the patient, and we're showing them the pictures, we're showing them the x-rays, we're showing them models, they have a pretty good idea of what's going on in their mouth. And this is all part of really getting that patient educated. So when you get to the treatment plan and the cost and so forth, they really understand what you're doing and why you're doing it. And you're also getting their input, what their priorities are, and what's important to them. And you can see a lot of wear. There's some wear, loss of vertical, a little bit edge to edge in the front. And we all know that by opening the vertical a little bit, we're also get a little better anterior relationship between the upper and lowers. It makes it easier to get a little more vertical overlap. Here you can see the posterior occlusals, lots of wear, lots of faulty restorations. You can see some cracks. And so this clearly is a patient that needed a full mouth reconstruction. Okay, so here's our diagnostic models, our diagnostic digital workup. We did our face bow, interocclusal registration. This is actually the diagnostic models. We do this at a slightly open vertical dimension by making an anterior stop and kind of guesstimate it at the vertical. Here's our x-rays again. And then we show the images, do our consultations. We do our treatment plan, talk about the costs. And now we're ready to do our digital workup. Here we do it a little differently. We're doing this, we did this actually with a restorative material, a printable restorative material. It looks a little more natural. So this is the way we like to do them now as professionals. And so now when you're presenting your case to the patient actually sees something that really looks, that actually looks pretty nice. You're not just showing a model with a bunch of wax, that doesn't really look like teeth. So you compare these models to the pre-op models, and they can get a pretty good idea of the changes that you're going to make. Final consultation, now we do our plan of treatment. We talked about that. We're going to write down all our appointments. Okay, first thing we're going to do is finalize our vertical dimension. We're getting it close. We're going to do our matrix bonding, very much like our husband, so we're not going to go through this, but for the same basic reasons. But I tell you, by doing matrix bonding, we can really get the patient started in their aesthetic evaluation. This patient, we made her teeth, a fair amount longer. Okay, we got pretty good proportion, but again, she had a fairly low lip line, so it really wasn't all that significant. And so now we wanted the patient to start to get used to that, and we also wanted the patient to start to get used to our new occlusal scheme. So this takes about 2 hours. I call it being the hero right from the very beginning. And again, you can see the patient after a few weeks is even smiling a lot bigger because now she actually likes her teeth. But the question is, are they too big? Are they going to be okay? And it gives the patient time to start to get used to this. Some people are fast adapters, some people are slow adapters. And again, if you can give them a little more time with the matrix bonding, then we go to our provisionals and even our final restorations, which we're going to show you provisionally cemented. It gives you a lot of time to evaluate, the final contours. And so when you do a permanent cementation, the patient's happy, and you really have successful patients, and you'll get those referrals. Again, materials, we're going to use similar materials. We did Emax veneers, layered zirconia in the upper aesthetic area, and monolithic multi-layered zirconia. So here's our first phase. Now notice we got a little blue stop here. That blue stop was made by using the vacuform that we made from our diagnostic digital workup. And this allowed us to put the patient at her final vertical that we determined with our diagnostic diagnostic workup, and we simply just put the vacuform on, put a little liquid blockout resin in there, and made an anterior stop at that vertical dimension. Okay, so now we can finalize our vertical dimension with our veneers in our first phase. So we can get a correct vertical one pretty close. So these are veneer preps. We're putting some matrices on here so we don't etch the adjacent teeth. And again, I'm just showing you tidbits of the sequence, not a detailed sequence. And then we go ahead and deliver those lower 8 veneers. Now we've got our initial color established, and we got our hopefully our final vertical dimension. Now we can still modify it a little bit if we want to. Okay, but now we give this a little bit of a period of time to see if it's going to work. And then we continue. So now we did have a slight open bite in the posteriors, which again I'm not that concerned about, and we were ready to start our treatment sequence. And we went ahead and did her anterior uppers much like her husband, but it was clear that this woman had a little bit of trouble opening her mouth a lot, and for a significant period of time it was difficult. So we did this as the first, well actually the second treatment phase. We'd already delivered the lower veneers, but these we're going to prep all at once and deliver them all together. So we decided that we're going to break this into multiple appointments just to minimize the amount of trauma to the patient. So we prep the, this is her lower right. We did that in 2 steps, and then we did the posterior right, and then the posterior left. We did those in 2 phases. So it took us 6 different prep appointment to prep all the teeth and get the patient in provisional. So now we've got a lot of prep teeth, and we got a lot of dyes, but now we got to start putting it all together. Okay, so here you can see her upper provisionals. Again, she has a low lip line. One thing, notice here that there were some thin areas. I was very conservative with my preparations. And this is one of the problems you have with really dark teeth, that if you use a kind of an opaque cement, you do get these discolorations. And we talked about that and decided whether or not it was going to be significant. But she had a fairly low lip line, so it wasn't really all that big an issue. But you can see how conservative I was with my my preparations. Slight anterior open bite. Then we went ahead and here we completed all our preparations and all our provisionals. The patients had a time to wear this, get used to it, and now we were ready to start finalizing our restorations. So we do what's called a substructure appointment. And this is a complicated appointment, but it's just a matter of following the steps that we teach. And so what we do is we go ahead and fabricate acrylic copings, like a little acrylic crowns on all our dies. We use these to test the accuracy of the dies. And then we put them in the mouth one by one. We check them. We lute them all together, do pickup impressions. and then we do interocclusal registrations at the vertical dimension we established with our provisionals by making an anterior stop. And then we also do a face bow and interocclusal registration for the provisional model. So we mount the provisional model to give us a guide in the fabrication process. And then we finalize our aesthetic prescriptions and pick out our materials. So here you can see all the aesthetic copings on here where we check all the margins to make sure our dies are accurate, lute them all together, do our pickup impression, and then we can put all our dies in this model, and then we fabricate really a solid model. These are actually the duplicate dies, and then we use the original dies. We scan those for our margins. Now these margins are pretty accurate as well, even though they're duplicate. So we've got a pretty accurate solid model, and then we superimpose the accurate margins of the original dies, and then we consolidate all of that digitally, and then we start our digital fabrication of our crowns. And here you can see the mounted upper provisional model, and this is mounted opposing the lower die model, and so we can use this to really get a good idea, to give our lab a good idea of how we want this designed. And in our prescription, we say what we like and don't like. So this is a upper provisional model, face bow mounted, and again, we use that as a guide for the final restorations. Interocclusal registrations, which we took before we took everything off. This was our upper, with all the provisionals, lower veneers, measure the vertical, and we take our interocclusal registration and mount everything at that vertical dimension. So the upper model, upper provisional, and the upper and lower solid models are all mounted and cross-mounted. Now for ceramic fabrication, I don't like to do a lot of adjusting, so I'm going to go only restore the maxillary arch first. We go to full contour. We're going to try those in. Going to do any adjustments necessary, compensate for any errors or changes, and then we take a bite registration to the lower prepared teeth. Okay, that lower solid model. Okay, so that's the first try-in appointment, so we don't make the lowers. And then we go ahead and fabricate the mandibular restorations. By doing it in this sequence, you really minimize the amount of occlusal adjustment. And occlusal adjustment, as you know, can be very, very time-consuming if you're a little bit off in your bite. So by getting the uppers done, we really have a very small space between the upper final restorations and lower preparations, and it makes it very accurate. Now in this particular case, I decided to provisionally cement it. And I like provisionally cementation. A lot of people are paranoid about doing this. I've done it for many, many years. One thing nice about it is I just go ahead and cement things. I don't even show the patient necessarily. We've already kind of showed them with our provisionals. We haven't made that big a change. But I go ahead and put it in. In some instances, you may have some tissue irritation. You may have some redundancies. You may have some issues that you want healing up. You may have some things you want to evaluate. And if you just try to permanently cement things, it becomes difficult. And so if you provisionally cement, I call that a test drive, it gives the patient the opportunity to wear these. I usually like to do it for a couple of weeks. Now this particular patient ended up wearing it for 2 or 3 months. Unfortunately, we lost one crown. So I just had my lab mill out a new one. It was no big deal. But normally I like to keep it for a couple of weeks. And we talk about how to do this and make it predictable and how to remove these. And it really isn't all that complicated. But by the time you finish your provisional cementation process, everything's healed, everything's nice, the occlusion is all stabilized, because you know everything's going to move a little bit. The patient has had plenty of time to evaluate it, and if you do need to make any changes in the aesthetics, the occlusion, or whatever, maybe ponic design possibly, although there's no ponics in this case, you can do that. If you just permanently cement them, you're kind of stuck with whatever you have. So this allows us to really give that patient the best possible treatment that we can. It means really one extra appointment, but it really allows us to end up with a great result. And you need to figure that into your cost a little bit. So as far as final cementation, anything that has normal retention and zirconium, we use a resin modified glass ionomer. I mean, we get into all the materials and the different types of cements and so forth. If we have a case where we have a minimal amount of retention, certainly like our veneers, we use resin bonded cements and bonding agents and sometimes total etch or selective etch. Again, it depends, and we get into that into the program. So here you can see our before and after. We made her teeth really pretty significantly longer, but she had a very low lip line. So we wanted to give her, a nice aesthetic smile, and you can see how it follows her lower lip nicely. Her upper teeth originally were worn and just really too short. Here's our before, after close-up. Put a few little characterizations in there to make them a little more natural looking. Before and our after. And again, if you look at the length width ratios, these would be long. But when you're looking at someone with a low lip line, we don't use length width ratios. We use incisal edge position. And we talk a lot about aesthetic design in the program. And there are post-op treatment, post-op x-rays, evaluation. We do this actually before we do our permanent cementation. And then we make our post-op orthotic very much like we did with her husband. And again, we evaluate their compliance and something to protect their investment. So if you're interested again in learning more about how to handle and sequence and deal with kind of advanced fixed prosthodontic cases, I'd invite you to attend our class on September 22nd and 23rd. And if you're interested in doing our entire mentorship program, these are the first couple of days. So it allows you to come in, check us out, see what we're all about. And again, it's aesthetic professionals in Tarzana, California. Hope to see you in September. Again, my name is Bruce Crispin. Thanks a lot.